USMLE style question on Graves' ophthalmopathy. Question: a 38-year-old woman presents to the clinic with progressive eye bulging, excessive tearing, and a gritty sensation in her eyes. She was diagnosed with Graves' disease 6 months ago and has been on methimazole therapy. Physical examination reveals bilateral proptosis, periorbital edema, and lid lag. Laboratory tests show low TSH and elevated free T4 levels. Which of the following best explains the pathophysiology of this patient's eye findings? A. Increased production of aqueous humor leading to intraocular pressure elevation. B. Lymphocytic infiltration and fibroblast activation causing glycosaminoglycan GAG accumulation. C. Immune complex deposition in the extraocular muscles. Direct stimulation of adrenergic receptors leading to increased sympathetic tone. E. Increased vascular permeability leading to protein leakage into the periorbital space. Answer B. Lymphocytic infiltration and fibroblast activation causing glycosaminoglycan GAG accumulation. Explanation: this patient has Graves' ophthalmopathy, thyroid eye disease, a characteristic feature of Graves' disease. Pathophysiology of Graves' ophthalmopathy: autoimmune activation of thyroid stimulating hormone receptor, TSHR, on orbital fibroblasts, lymphocytic infiltration of extraocular muscles and retroorbital tissues. Fibroblasts secrete glycosaminoglycans, GAGs, like hyaluronic acid. Increased osmotic pressure leads to muscle swelling, fat expansion, and fibrosis. Proptosis, exophthalmos. Periorbital edema and inflammation, ophthalmoplegia, restricted extraocular movement in severe cases. Why not the other options? Increased production of aqueous humor occurs in glaucoma, not in Graves' ophthalmopathy. C. Immune complex deposition in extraocular muscles, seen in conditions like systemic lupus erythematosus, SLE, but not Graves' disease. D. Direct stimulation of adrenergic receptors explains lid lag and lid retraction, but not the inflammatory orbital findings. E. Increased vascular permeability, seen in inflammatory or allergic reactions, but the primary issue in Graves' ophthalmopathy is fibroblast activation and GAG accumulation. Next steps in management: first-line therapy, high-dose glucocorticoids, reduce inflammation. Severe cases, orbital decompression surgery. Definitive treatment, thyroidectomy or radioactive iodine, but RAI may worsen ophthalmopathy.